Welcome back to the deep dive. So today we are shifting gears. We aren't looking at policy papers or tech trends or, sociology. We are putting on the lead aprons, grabbing the ultrasound probe, and scrubbing in. We have a massive stack of sources on the desk clinical guidelines from the World Society of Emergency Surgery, the Surgical Infection Society,
Yeah.
some incredibly detailed anatomical atlases, and some very, very aggressive protocols on source control. And honestly, looking at all this material, I feel like I'm back in the resident's workroom at 3 a.m. drinking just awful coffee and, trying to keep a patient alive.
It definitely has that specific high-stakes intensity, doesn't it?
It really is.
And rightly so, because the topic today isn't just abdominal pain or a bit of sepsis. It's the concept of the hostile abdomen. We're talking about peritonitis, deep space abscesses, and the absolute physiological catastrophe that happens when the peritoneal cavity, which is usually just a potential space, decides to become a shock organ.
I love that framing, the peritoneum as a shock organ.
Ah.
We usually compartmentalize, right? And we think of the heart failing or the lungs failing in ARDS. But the abdomen is this black box in the middle of the body that can drive all of that failure.
Precisely. You have to view the peritoneum as, well, effectively as a second skin, but turned inside out. It has a surface area roughly equal to your body's skin surface. I mean, imagine if your entire skin was burned or infected all at once. That is the level of cytokine dump, the fluid shift, the inflammatory cascade we're talking about with diffuse peritonitis. You can have a patient in the ICU who is just physiologically crumbling vasopressors are maxed out, lactate is climbing, the kidneys are failing, and if you are just staring at the white blood cell count or waiting for some positive sign on a physical exam in a sedated patient, you are going to lose them.
That is the terrifying reality. If you don't respect the geography of sepsis, it will kill your patient while you're wondering why the broad-spectrum antibiotics just aren't working.
Exactly. The abdomen is unforgiving. It hides things. So our mission today is to build a mental model for the practicing intensivist. We need to move beyond the basic start Zosyn and consult surgery algorithm. I mean, that's for interns. We're going to parse this material to build a masterclass in advanced anatomical search patterns, literally, where does the pus hide? We're going to debate the nuanced decision-making for source control, the whole drain versus operate debate, and we're going to get into the weeds of drain management, intra-abdominal pressure, and, of course, antibiotic stewardship.
And we need to be specific. Generalities don't save septic patients. We have to talk about fluid dynamics, about specific ligaments that act as barriers, and the exact criteria for when a drain has failed.
Correct. We are going to parse this sentence by sentence if we have to.
Okay, let's start with the geography. One of the most striking things of the source material is this idea of treating the abdomen like a topographical map. It's not just a sack of organs. It has hills, valleys, watershed moments.
That is the single biggest mistake clinicians make. They look at the CT report that says small amount of free fluid, and they move on. But you have to understand the physics of the abdomen. It's a dynamic environment governed by two things: gravity and pressure.
The sources mentioned the respiratory pump. This was fascinating to me because it feels almost counterintuitive, regarding how infection spreads. Break that down for us.
It is basic physics, but we often forget it in the heat of the moment. When you breathe, specifically during expiration, your diaphragm relaxes and moves up toward the head. This creates a negative intrathoracic pressure. The negative pressure is transmitted through the diaphragm, and it acts like a suction pump. It literally pulls peritoneal fluid from the pelvis up along the pericolic gutters towards the subphrenic spaces.
Okay, hold on. Let me get this straight. Gravity is pulling everything down, but every single time the patient breathes out, the diaphragm is trying to wick fluid up.
In an upright person, sure, gravity usually wins. But think about our patient. Where are they?
In the ICU. Supine.
They're in the ICU. They're flat on their back. So gravity is absolutely pooling fluid in the dependent spaces, Morrison's pouch on the right, and the pelvis. But that respiratory pump is still active. It is constantly trying to pull that inflammatory fluid up the gutters toward the diaphragm. This is why you get subphrenic abscesses, these collections right under the rib cage. Even when the original problem was way down in the appendix or the sigmoid colon, the pus travels.
That explains the spread. Okay, now, the sources talk about the Great Divide, the transverse mesocolon, and the root of the mesentery. These aren't just anatomical labels. They're like physical barriers for this fluid, right?
They are dams. The transverse mesocolon is a shelf. It divides the abdomen into upstairs, the supracolic compartment, and downstairs, the infracolic. But the root of the mesentery, that is the real game changer for the intensivist reading a scan. It runs obliquely from the upper left at the ligament of Treitz down to the lower right at the ileocecal valve.
It cuts across the abdomen diagonally.
Exactly. And because of that angle, it creates a very specific flow pattern. It prevents fluid in the right infracolic space from crossing over to the left. It essentially traps it there. But the left infracolic space, it's an open slide. It just dumps fluid straight down into the pelvis.
So, clinically speaking,
Yeah.
if I have a leak on the right side, say a right hemicolectomy that leaked, that might stay contained locally.
It has a much higher chance of staying local or maybe moving up towards the liver. But a leak on the left,
From the sigmoid.
from diverticulitis, that is almost guaranteed to slide right down into the pelvis. So if you have left-sided pathology, you better be scrolling all the way down to the rectum on that CT scan, or you will miss the collection.
Let's operationalize this then. The guidelines outline a cockpit checklist for reading a CT scan, the big 6 dependent spaces.
I want to walk through this with a hypothetical case to really make it stick.
Let's do it. Okay, let's say we have a patient post-colectomy, day 5. They have this vague sepsis. Their white count is actually normal, which we know can happen in immunosuppressed or just overwhelmed patients, but they just look off. Lactate is 2.5 and it's creeping up. We get the CT with IV contrast. Where are we looking step by step?
Okay, open the mental retractor. We're going to ignore the bowel for a second and just look at the spaces. Step 1, right subphrenic space. You look between the liver and the diaphragm, but here's the pearl from the source material. Don't just look at the abdomen. Look at the lung base.
The lung base, you mean
Yeah.
above the
Yeah.
diaphragm.
Yes. Look for sympathetic effusions. If you see a reactive pleural effusion on the right, you have to assume there is pathology immediately below the diaphragm until you can prove otherwise. The diaphragm is porous to inflammation. The lung knows there's pus below it, sometimes before you can even see the abscess itself.
That's a great tip. So pleural effusion on the right equals check the liver dome. Okay, space number 2.
Right, subhepatic or Morrison's pouch. This is the deepest point in the upper abdomen when a patient is supine. It is the canary in the coal mine. If there is free fluid anywhere in the belly, it will settle here first, even just 30 to 50 cc's.
So if I see that dark stripe separating the liver from the kidney,
You have a problem. That space should be tight. If there is fluid there, you have to ask, is that pus, blood, or ascites? In a post-op patient, you assume it's infected until proven otherwise.
Okay, moving on. Space number 3. The sources call this the sanctuary site, the lesser sac.
This is the one everyone misses. The lesser sac is a potential space behind the stomach and in front of the pancreas. It is a trap. The sources call it the hidden highway because it technically only has one door, the foramen of Winslow, the epiploic foramen.
And if that door gets scarred shut from previous inflammation or surgery,
Then it's a sealed tomb. You can have a massive abscess in the lesser sac liters of pus that does not communicate with the rest of the abdomen at all. It won't show up in the gutters. It won't show up in the pelvis. It won't show up on a FAST exam. You have to specifically look behind the stomach on the CT.
the professor in the source material uses a verbal cue here that I love. He says, now let's open the mental retractor and look behind the stomach.
It's a necessary discipline.
Yeah.
Because the stomach is filled with air and fluid and the pancreas is right there. Your eye just tends to skip over the space in between. You have to force yourself to look at that retrogastric space. If you miss a lesser sac abscess, the patient will rot while you treat them for pneumonia because you missed the source.
That is a high-yield blind spot.
Okay,
Space number 4.
left subphrenic. This one is different from the right. It's protected by the phrenicocholic ligament.
Explain that structure.
It's a fold of peritoneum that connects the splenic flexure of the colon up to the diaphragm, and it acts like a dam. It prevents fluid from the left pericolic gutter from easily washing up into the perisplenic area.
So it actually blocks that respiratory pump effect we were just talking about.
Exactly. So left subphrenic abscesses are actually rarer than right-sided ones. But, and here's the catch, when they do happen, they're usually contained and much harder to drain because the spleen and the colon are right in the way.
We'll definitely get to the drainage issues in a bit. Space 5.
The bilateral pericolic gutters. These are the highways. Puss uses these to travel between the attic, the subphrenic spaces, and the basement, which is the pelvis. You scan them for fat stranding.
Describe that for the listener who isn't a radiologist. What does fat stranding actually look like?
Normal fat on a CT scan is dark gray and smooth, like clean butter. Stranded fat looks like dirty wool. It's hazy, it's white, it's streaky. If the fat in the gutters looks dirty, pus has traveled through there, period.
And finally, space number 6.
The pelvis, the sump of the abdomen, the rectovesical or rectuterine pouch. Gravity wins eventually. Everything drains here. And in a supine patient, this is deep. It's below the level of the bladder dome on the scan. You have to scroll all the way down until you see the rectum exits the pelvic floor.
So that's the checklist.
Right.
Subphrenic, Morrison's, lesser sac, left subphrenic, gutters, pelvis. If you scan those 6, you're going to catch 90% of collections. But the sources also mention how surgery changes the map, specifically things like Roux-en-Y anatomy or any major reconstruction.
Oh, completely. The map we just described assumes normal anatomy. When you rearrange the bowel like in a gastric bypass or a Whipple procedure, you cut the mesentery. You create defects. A normal abdomen has predictable drainage. A post-surgical abdomen has trapdoors.
You mean like internal hernias?
Yes, and loculations in places that shouldn't exist. A Roux-en-Y patient with sepsis it's a nightmare because the anatomy is non-Euclidean. You cannot rely on standard flow patterns. Puss can be trapped in a mesenteric defect that didn't exist before the surgery.
There's one more anatomical mimic the sources warn about, the retroperitoneal mimic. This feels like a classic board question.
It's a clinical disaster. Here's the scenario. You have a patient with sepsis. Lactate is 4. They're tachycardic. But you push on their belly and it's soft, it's not rigid, they don't have peritonitis.
So the resident says it's not the belly, the exam is benign.
And the resident is wrong. Let's look at the vignette from the source. A patient has a duodenal perforation pointing backward or severe necrotizing pancreatitis tracking into the anterior perirenal space. That pathology is behind the peritoneal sac.
So it's not irritating the parietal peritoneum.
Exactly. The parietal peritoneum is what gives you the pain and rigidity, the somatic pain. If the pus is behind that, you don't get the board-like abdomen. But the patient is rotting from the inside out. They have retroperitoneal sepsis with minimal peritoneal signs.
That is a dangerous phrase.
It requires a high index of suspicion. The CT is the truth teller here. You just cannot rely on the physical exam for the retroperitoneum.
Okay, we've mapped the territory, we've found a collection on the scan, now we have to make a decision. The sources outline a very aggressive executive pathway for source control.
And it starts with a binary decision, unstable versus stable.
If there are unstable shock, rigid abdomen, the sources are pretty blunt.
Do not pass go. Do not get a CT. If a patient has peritonitis and hypotension, that is a physiological catastrophe. You resuscitate, what we call damage control, and you go straight to the operating room. You open, you control the spillage, you get out. No time for pictures.
But most of the time in the ICU, we have a little stability. We get the CT with IV contrast. Now we have the great debate. Is this a phlegmon or an abscess?
This is the most common argument between intensivists and surgeons at the console. A phlegmon is solid inflammation. It has a high density on CT, usually over 20 Hounsfield units. There's no liquid center.
It's a brick, not a balloon.
Right. You can't drain a brick. If you stick a needle in it, you get nothing.
So the action there is antibiotics and wait.
Antibiotics and serial imaging. You wait 48 to 72 hours. It will either resolve with the drugs or it will liquefy into an abscess.
And if it's an abscess?
You see a liquid center, low density, and a rim-enhancing capsule. That needs drainage. The Latin maxim is ubi pus, ibi evacua, where there is pus, evacuate it.
But do we drain it with a needle, with percutaneous drainage, or do we cut it out with surgery?
The default now is PAD, percutaneous drainage. If it's well-formed, accessible, and over 3 centimeters, interventional radiology is the way to go. It saves the patient the trauma of a laparotomy. We avoid the zipper. We avoid the hernia risk.
But there are exceptions. The sources list specific surgical criteria where PAD is just destined to fail.
Absolutely. First, if you have diffuse contamination poop everywhere, a drain won't work. You need a washout. Second, if you have necrotic bowel, a drain will not fix dead tissue. And the big one, interloop abscesses.
Explain those. That sounds tricky.
Remember the fibrin we talked about? Inflammation creates this fibrin glue. It traps pus between loops of small bowel in a honeycomb pattern.
A honeycomb.
Yes. And you cannot drain a honeycomb with a straw. You might drain one cell, but the other 50 are still full of pus. You need to go in surgically and break up those adhesions. Wash it out manually.
The sources also mention the phrenicocholic ligament again here as a barrier to PAD.
Right. If you have a collection high in the left subphrenic space, sometimes there's just no safe window for a needle. The spleen is in the way. The colon is in the way. You can't stick a needle through the colon to get to the pus. That just creates a new hole. That's a surgical case.
And what about coagulopathy?
Well, if the patient has an INR of 3.0 or platelets of 10,000, sticking a large bore needle blindly through the liver or muscle is just asking for a hematoma. Surgery allows you to control hemostasis directly.
Here's, I think, the most critical takeaway on this section, though, the 48-hour reassessment rule.
This is the law of the intensivist. If you have intervened, whether you put in a drain, started antibiotics, or did surgery, and the physiology has not turned around in 48 hours, source control has failed.
Define physiology here, because sometimes the white count stays up for a while.
I don't mean the fever is gone or the WBC is normal. I mean, are the pressors coming down? Is the lactate clearing? Is the mental status improving? If the patient is still in shock, or if their organ failure is progressing 48 hours later, you are missing something.
And this is where people get killed, isn't it? They say, well, the drain is in. Let's just give the antibiotics more time to kick in.
No, that is the sunk cost fallacy of medicine. If the patient is still in shock 48 hours later, the drain isn't working, or it's clogged, or there's another abscess you missed, you need to re-image immediately. Do not wait.
And on that re-imaging note, the sources warn about the early CT pitfall.
Yes. If you scan a post-op patient on day 1 or 2, everything looks like a mess. It's unorganized fluid, edema, air. You get false negatives. You might see fluid and think, oh, that's just a post-op seroma, but it's actually an early anastomotic leak.
So how do you know?
You treat the trend, not just the single snapshot. If the patient is getting worse, you have to assume the scan is lying or at least undercalling it and look harder. Sometimes you have to take them back to the OR based on physiology alone, even if the scan is equivocal.
Let's zoom out a bit. Part 3 of our deep dive covers the classification of these infections, the 3 peritonitis syndromes. This isn't just academic labeling. This changes the treatment entirely.
It's crucial to categorize these correctly because the treatments are diametrically opposite.
Okay, start with primary peritonitis, or SBP, spontaneous bacterial peritonitis.
The definition: a monomicrobial infection, usually translocated bacteria like E. coli or Klebsiella, but importantly, there is no hole in the gut.
And the typical patient.
The cirrhotic with ascites, the nephrotic patient, someone with fluid already in there.
And the management.
It's medical. Antibiotics and albumin. And this is key. If you take a decompensated cirrhotic with SBP to the operating room because you think they have an acute abdomen, you will likely kill them. The stress of surgery, the coagulopathy, the loss of tamponade, it's a disaster. You treat this with meds.
Okay, contrast that with secondary peritonitis.
This is the surgical bread and butter definition. There is a physical breach in the GI tract, a perforation, a leak, ischemia,
Microbiology.
polymicrobial, you've got the whole zoo, E. coli, bacteroids, enterococcus. Everything that lives in the gut is now spilling out.
And management.
Source control is mandatory. You have to sew the hole or drain the collection. Antibiotics are secondary. You can give all the meropenem in the world, but if there is still a hole in the colon, they will die.
Now for the scary one, the one that keeps intensivists up at night. Tertiary peritonitis.
This is the failure state.
Yeah.
The definition is persistent sepsis more than 48 hours after you think you've had adequate source control.
So we operated, we washed it out, we gave the drugs, and they're still septic a week later.
Exactly. And the microbiology shifts. The E. coli is dead. We killed it with the ceftriaxone.
Yeah.
Now you have the low virulence, high resistance bugs, Enterococcus, Candida, Staphylococcus epidermidis.
Why those specific bugs?
Because we selected for them with our initial antibiotics, but also the pathophysiology itself changes. The sources talk about immune paralysis or PICS, persistent inflammation, immunosuppression, and catabolism syndrome.
So the patient's immune system isn't just fighting an infection anymore. It's exhausted.
It's stunned, it's unresponsive, and you have biofilm forming on every foreign body. The drains, the meshes, the staples, the bacteria are hiding in these slime layers where antibiotics can't reach them.
So how do you manage tertiary peritonitis? It sounds like a dead end.
It's incredibly difficult. You have to search aggressively for undrained foci, those hidden pockets. But you also have to recognize that more surgery might not help. Sometimes you open them up and it's just concrete abdomen, frozen bowel, no discrete abscess. At that point, it's about nutritional support and, frankly, recognizing the limits of what we can do.
The sources mentioned 2 scoring systems here, the MPI and the WSES. Why do we need scores?
They help with reality testing. The Mannheim Peritonitis Index, the MPI, is an intraoperative score. It looks at what the surgeon found. How bad was the soilage? Is it clear fluid or is it fecal peritonitis? It predicts death based on the surgical finding.
And the WSES sepsis severity score.
That's better for us in the ICU. It's a global risk score you can use immediately post-op to guide triage. It helps you justify why this patient needs 1.1 nursing and aggressive monitoring. It tells you this patient has a 40% mortality risk, act like it.
Okay, let's talk about the hardware. Part 4, drain management. We've decided to drain. The IR team puts the tube in. Now it's sticking out of the patient. How do we troubleshoot it?
I call this the art of the drain. A drain is not a set it and forget it device. It is a window into the abdomen. It is both diagnostic and therapeutic.
Okay, let's run some scenarios. Scenario 1, you have a drain putting out 100 cc's of pus a day. Suddenly, overnight, it goes to 0.
That is a huge red flag. Abscesses rarely cure themselves instantly at midnight. If it goes from 100 to 0, it's not cured, it's clogged. Or it kinked. Or it migrated out of the pocket.
Action.
You have to flush it, check the tubing, and if that doesn't work, you image. You need to see if the collection's still there. Do not assume no output means no puss.
Okay, scenario 2. The drain is putting out 500 cc's a day, every day, for a week. Looks kind of serous, maybe a little bile stained.
Persistent high output. That means you aren't draining an abscess anymore. You're draining a fistula. You are draining a leak.
How do we figure out what is leaking?
Send the fluid. This is such a simple, high-yield tip that gets missed all the time. Send the drain fluid for creatinine. If it's high, higher than serum, it's urine. You have a leak from the bladder or the ureter, send it for bilirubin. If it's high, it's a biliary leak. Send it for amylase. If it's high, it's pancreatic.
That turns the drain into a diagnostic tool. Instead of just guessing, you just ask the lab.
Exactly. Don't just look at the color. Analyze the chemistry.
Right, scenario 3. IR puts a drain in, and an hour later, the patient crashes. BP drops, rigors, fever spikes to 40 degrees C.
The septic shower. This is classic. When you manipulate an abscess, shoving a wire into it, dilating a tract, you increase the pressure inside that cavity. You can force bacteria and endotoxins into the bloodstream. It's a transient bacteremia.
It scares the hell out of the nurse. Do we pull the drain?
No, do not pull the drain. That's the only thing saving them. You manage the shock, give fluids, give pressors, make sure antibiotics are on board. It will pass. But the drain needs to stay in to evacuate the source.
So when do we pull the drain? The
Yeah.
sources have a safe exit checklist.
2 criteria. 1, clinical resolution. The patient is better. 2, low output. The rule of thumb is usually less than 10 millirels per 24 hours.
And there's a crucial step before you actually pull it.
Confirmatory imaging. You have to prove the cavity's collapsed. Do not pull the plastic until you have a CT scan showing the abscess is gone. If you pull it too early, the skin closes, the pus reaccumulates, and you're right back to square one.
Let's switch gears to pressure. Part 5. Intra-abdominal hypertension, IAH.
This is the silent killer in the ICU. We monitor blood pressure, intracranial pressure, but we often ignore abdominal pressure until it's way too late.
Definitions first. What are the numbers we need to know?
IAH, intra-abdominal hypertension, is a sustained intra-abdominal pressure, or IAP, greater than or equal to 12 milliblen Hg. ACS, abdominal compartment syndrome, is pressure greater than 20 millimilla Hg plus new organ dysfunction.
Why does high pressure in the belly cause organ failure everywhere else?
It's a vicious cycle. High pressure compresses the renal veins. That causes congestion in the kidneys. The blood can't get out, so the filtration stops. You get AKI, acute kidney injury.
So the kidney failure isn't just dehydration.
No, it's congestive. It also compresses the gut microvasculature, causing gut ischemia. That leads to more edema, which raises the pressure further. It pushes up on the diaphragm, crushing the lungs so your ventilator pressures go up. It compresses the IVC, dropping venous return to the heart. It affects everything.
How do we measure it properly? I feel like this is often done wrong at the bedside.
It has to be precise. The standard is bladder pressure. The patient must be supine. You measure at end expiration. You zero the transducer at the mid-axillary line, not the phlebistostatic axis. And here is the key where everyone messes up. You instill a maximum of 25 millibars of saline into the bladder.
Why max 25? I see people putting in 50 or 100 sometimes.
If you overfill the bladder muscle itself stretches and contracts. That gives you a falsely high reading. You're measuring the bladder tone, not the abdominal pressure. You want just enough fluid to create a column, a continuous water path to the transducer. 25 millibars is plenty.
If we find ACS pressure is 25, kidneys are failing, the vent is alarming, what do we do?
Medical management first. Deep sedation, paralysis to relax the abdominal wall muscles, NG decompression to suck out air. But if that fails,
It's surgery.
decompressive laparotomy. You open the belly, the fascia springs open, the guts bulge out, and usually the urine output starts instantly. It's the ultimate source control for pressure.
Okay, let's move to the pharmacy. Part 6. Antibiotic stewardship. We had the STOP-IT trial, which really shook things up a few years ago.
The STOP-IT trial is a landmark. It showed that for complicated intra-abdominal infection, 4 days of antibiotics is equal to longer courses. IF source control is adequate.
That IF is doing a lot of heavy lifting in that sentence.
It is the whole point. The trial proves that antibiotics are just the cleanup crew. If you have drained the abscess or closed the hole, 4 days is enough to mop up the residual bacteria. If you haven't achieved source control, 14 days of antibiotics won't save you.
So the nuance is, treat the physiology, not the scan.
Exactly. You will often see persistent stranding or inflammation on a CT scan at day 4. That does not mean you need more antibiotics if the patient is a febrile and eating. Stranding takes weeks to go away. Don't treat the stranding, treat the patient.
Let's talk about empiric selection. What do we start with?
If they're community acquired, someone coming in from home, we stick to the basics. Ceftriaxone and Flagyl, metronidazole.
No Cipro. I still see Ciproflagyl used a lot.
You should avoid Cipro. E. coli resistance to fluoroquinolones is just too high now in many regions. It's not a reliable empirical choice anymore.
And for healthcare associated, post-op patients or those who have been in the ICU for a week.
You have to broaden Piptazo, Zosyn, or meropenem. You need to cover Pseudomonas and the resistant gram-negatives.
When do we add the heavy hitters? When do we add vancomycin for MRSA?
Only if they are known to be colonized with MRSA or if they are in hemodynamic shock. We don't cover MRSA routinely for belly infections. Staph aureus is not a common gut bug.
What about Enterococcus, VRE?
This is controversial, but generally you target E. faecalis, which Zosyn covers initially. You only add vancomycin or linezolid for VRE if they are high-risk liver transplant patients or those with long-term cephalosporin exposure.
And the fungal question, Candida. This is a constant debate.
It is. Here's the heuristic. In community-acquired, do not cover fungus routinely. It's rare.
But in healthcare associated?
Yes, if they meet certain criteria. Septic shock, yes.
Yeah.
Upper GI perforation, yes, because the stomach and duodenum have a higher fungal load than the colon. Or, and this connects back to our earlier conversation, tertiary peritonitis. If they have been treated and failed, you have to assume Candida is playing a role.
Okay, final clinical section, Part 7, PD peritonitis. This is a niche, but when the nephrology world crashes into the ICU, it causes a lot of confusion.
PD, or peritoneal dialysis, peritonitis is unique. The catheter is the vector. The peritoneum is being used as a filter.
Diagnosis, the rule of 2.
You know, 2 out of 3. 1, pain or cloudy effluent, so the dialysis fluid looks milky. 2, a WBC in the fluid greater than 100 with more than 50% PMNs. And 3, a positive culture.
And there's a massive trap here called the enteric trap.
Huge. If you get the culture back and it grows multiple enteric organisms, E. coli plus S. Klebsiella plus S. anaerobes, that is not touch contamination.
People think, oh, grandma didn't wash her hands when she connected the bag.
Wrong. If you see multiple gut bugs, that means there's a hole in the gut. That is a visceral perforation. Diverticulitis or appendicitis that has ruptured into the PD fluid, you need an urgent CT and a surgeon. If you just treat that with intraperitoneal antibiotics, they will die.
And finally, catheter management. When do we have to pull the tube?
We try to save the catheter, but there are hard stops. Rule 1, refractory. If the fluid isn't clear by day 5, it's mandatory removal. You save the peritoneum, you sacrifice the catheter. Rule 2, fungal PD. Immediate removal, do not pass go. You cannot clear fungus from a silicone catheter, it sticks to the plastic.
And once it's out,
you treat with antifungals for at least 2 weeks after removal.
This has been an absolute marathon. We've done from the diaphragm to the pelvis, from the first incision to the tertiary failure state. Let's try to synthesize this in the outro.
If I had to summarize this entire deep dive into one philosophy, it's this. Source control is king. Antibiotics are just the cleanup crew. You cannot medicate your way out of a surgical problem.
And use the heuristic decision tree. Ask yourself, is it primary? Give MEADS. Is it secondary? Call surgery or IR. Is it tertiary? Look for failure, but recognize the limits.
And remember the anatomy. Use the checklists. Don't be satisfied with the quick read. Look at the lung base. Look behind the stomach.
I want to leave the listeners with a final provocative thought from the sources. We talked about tertiary peritonitis and this idea of immune paralysis.
Yes. The sources hint at a shift. We've spent 50 years trying to find bigger antibiotics and bigger surgeries. But for those patients with the hostile abdomen who are in immune failure, the future might not be killing the bugs. It might be immunostimulation.
Reversing the exhaustion of the host.
Exactly. Giving the immune system a kickstart, maybe with interleukin-7 or checkpoint inhibitors like they use in cancer to finish the fight. That's the frontier.
Fascinating. So instead of poisoning the bacteria, we wake up the soldiers.
Mm.
All right, listeners, next time you are looking at an abdominal CT, I want you to mentally open the retractor and check the lesser sac. Find those pockets.
And check the drain fluid for creatinine.
Thanks for diving deep with us. We'll see you on the next one.
Stay curious.